before we put the implant in, we want to address the phalangeal surface. Sometimes, as in this cadaver, most of the phalangeal surface is pretty good, and there's just a little bit of dorsal osteophytes or dorsal spurs. Sometimes it's completely denuded of its articular cartilage. In all situations, the first thing we would want to do is release the spurs on the phalanx. And this reamer actually works very nicely to do that. And what we're going to do is actually take the guide wire, put it right into the center of the metatarsal, but I'm going to angle at about 45 degrees plantar, and I'll show you this on a lateral in a second. And so we have our guide wire in place, and we'll look at it. You can see that it's going down the center of the proximal phalanx on the AP, and then on a lateral, you can see that if this is the surface, we're at about a 45-degree angle. So actually the surface will be like that. You'll notice that the guide wire is at a 45-degree angle. The idea is we can actually remove these dorsal spurs. And so with our reaming, you'll notice that as I'm reaming, we're literally taking off the dorsal aspect of the phalanx. I'm just going to get to that subchondral bone, and I'm going to remove those spurs. So you'll notice that we've basically taken off the dorsal surface, and there's just a small amount of articular surface just in this most inferior aspect of the proximal phalanx. The rest has all been denuded down to good bleeding, basically right down to the subchondral area. I'll take a rongeur and just finish off any extra pieces in this area.
Again, like we've been talking all along, one of the most important things is to make sure it's clear, there's no impingement, no osteophytes, either on the metatarsal head or the phalangeal base. And I think that's something that people have a hard time getting aggressive enough with when they first start doing this implant.
And so you'll notice now with the trowel implant, and as I come up, there's still a nice space between the two as the toe dorsiflexes. And so you're not going to get that impingement of the proximal phalanx. And then I'm going to seat it down onto the post. At this point, you want to do the final Morse seating of the Morse taper. And so you'd actually take your impactive device, you'd hold it here, and you'd want to give it 2 firm blows with a mallet or an acetone or a mallet. And so I would actually personally give it a couple of good taps. Really, it's a Morse taper, so you shouldn't have to hit it hard, but you want to do it firmly. And now we have our implant in place. And so now, with the implant in place, and we've done all of our releases, we're going to check our toe and our motion. And you'll see the sesamoids going down and then coming back up as you move. So each time the toe moves, the sesamoids are still moving, and they're still attached. Even though we've done that release, you'll notice your sesamoids are still moving with your proximal phalanx.
You see how much joint we actually have here with all the soft tissue and all the decompression? You know, you can distract this joint, you can get a fairly large open joint. So you've got a nice loose joint. Like Dr. Hassman said a few minutes ago, just like knees and hips, you don't want them too tight.
And then with an AP on the implant, again, you just want to look at it. Actually, we'll go live floor on dorsiflex, plantarflex, and you'll see how the sesamoids are moving underneath, coming up onto the implant. And so that's exactly what you want when you're done.
Doing this, we've stayed medial to the tendon, so you've got plenty of capsule here to be able to pull this up and close, watching out for any of your neurovascular structures medially. So with this, just either a simple interrupted or a running deep closure with Vicryl, monocryl, whatever makes you happy, PDS, get it closed up and get the capsule totally closed so you recreate your joint environment. Then coming back with the skin, same thing. It's a closure of choice. On the foot here, I wouldn't have a problem using some sort of a running stitch, a interrupted horizontal, or a vertical mattress, whatever is your choice for closure for these patients. To me, the main thing is to get the skin good and closed with a nice good stitch to really aid you, because what you're looking for with these guys is to be able to get early range of motion.
We've closed the whole toe. I actually like to do a nice compressive dressing. I'll put a lot of 4x4s, pretty aggressive with my padding. I'll put web roll around it. I use an ACE wrap. Some docs like to use a Coban. It doesn't matter. You just want to make sure you have good compression. The other thing I think that is key is after you have done all your, you have your implants in, if you did not use a tourniquet, that's fine. If you use the tourniquet at this stage before I close, I would recommend you put the tourniquet down, make sure you have hemostasis. You don't want a lot of bleeding in here, which will cause a lot of swelling and problems and stiffness afterwards. So I would say that at this point, I have my implant in. Just before I would start closing capsule, I would actually put the tourniquet down, make sure that I have pretty good hemostasis. And then at that point, I would put them in a nice, well-padded splint, a well-padded soft dressing compressive. I put them in a post-op shoe, but I tell them the day after surgery, I want them walking around with just their dressing on. I want them out of the post-op shoe. I make them weight bear in their house, and they bear just their dressing. I say if you go outside, obviously, you put a shoe on, which would be the post-op shoe I would give them. But I tell them begin moving the big toe. I tell them I want them moving their big toe the day after surgery. It's on my discharge instructions because I want to get that motion. I don't want to lose it. No different. I tell a lot of people it's like a total knee, a knee replacement. You want those people moving their knee right away. You want them moving their toe right away. Don't hold them still. I've not had wound complications from moving them early. I know a lot of people worry about that. I think with the compressive dressing, it allows for some motion, but not so much motion that they get wound problems right away. So I'm pretty aggressive with that. Dr. Carpenter?
My dressing and post-op course is exactly the same. I really push them to get out of the shoe in the first 24 to 48 hours because they can think they're walking flat on their foot. We're human. You're always going to use your normal gait pattern and get a little bit more dorsiflexion than you will by wearing a stiff-soled shoe. So I think that's very important. I do the same thing, just a very well-padded compressive dressing. I feel much more comfortable with ACE wrap as well. Make sure we don't get any kind of skin problems as you can get with Coban, even though a lot of guys love the Coban. And most of my patients want to get back in their normal shoe anywhere between 10 and 14, 17 days. I leave the sutures in at least 2 weeks, sometimes closer to 3, depending on how much swelling they're still having, and get them back to normal activities as soon as possible.